Okay, folks, I'm gonna have a discussion with you and then kind of show you some things that I think we should definitely be doing if we get to the point that we are putting ourselves at risk because the patient needs some aerosolized generating procedure that we need to perform with this COVID-19 stuff. So I've been kind of, you know, researching, reading, listening to podcasts and things like that, and just some things that I've kind of decided I'm gonna do. My best practice is not the only practice, is just what I decided I was gonna do. And there's some rules here that I've been kind of figuring out that less is more. Just like Carrie said, think long and hard before we do these aerosolized generating procedures. This is a different thought process than what we are used to. We're used to going in, hitting the airway, intubating with delayed sequence intubation with apneic oxygenation and all that sort of stuff. We need to kind of pull back and think about this. First, the basics. How is this the SARS-CoV-2 spread? And it's droplets. It's droplet spread. So surgical masks on every patient. If they need oxygen, like a nasal cannula, put the cannula on quickly and put that surgical mask on them very quickly. I found that if Payette does go, they put a surgical mask on everybody, and that's awesome. I'm great with that. I'm gonna have my PPE on with my N95, my goggles, and my gloves on every time. If they are COVID patient or suspect, I'm gonna put this fashionable gown on, as Carrie says. Like Carrie said, these patients are kind of presenting with silent hypoxia, where they still look good. They're not crapping out on us really quickly with low sats and looking like they usually do. So when we see somebody with sats in 70s and 80s, they usually look really bad. Dyspneic, 2-3 word sentences at the most, if they can speak at all. But it seems like these, according to everybody else, I haven't seen a really bad sick patient, but that they're presenting where they're looking good, both low sats. And if we do less, it's less transmission time for us, okay? So if they're okay with a nasal cannula on at 3 liters and a surgical mask over the top of that nasal cannula, and they're still able to speak, they're not altered or agitated, then leave it. And even if their sats are still fairly low, lower than we normally like it. Carrie is saying these are clinical decisions that we're not used to making, but we're going to have to make. I've got to turn the light thing. It was almost to 0. Then we'll be dark in here while we're talking. So please avoid as much as we can any of those procedures that will aerosolize, and those are non-rebreather masks, BVMs, non-invasive things like CPAP, BiPAP, suctioning of airways, BVM, did I say that? So we have to be careful. Now, what is the high flow, high pressure thing that they want us to stay away from? How much oxygen is that through a mask or through a nasal cannula? And they seem to not really know, but they keep kicking around the flow rate of 6 liters per minute. Anything more than that will possibly aerosolize. So if I'm doing a nasal cannula, I'll tell you what, I'm going to go to 5 liters with that surgical mask over the top. And I'm going to sit there and wait. And if I'm treating the patient right now, I'm not treating those numbers. And we'll just be explaining that in our charts. at 83% hypoxia on their SpO2, and they're still able to talk and not confused and not agitated and stuff, then it's going to stay that way. If they do show some signs of confusion, hypoxia, agitation, that sort of thing, where they're altered, they have agitation, because you know how fast an agitated patient aerosolizes stuff or spits or whatever. So we're going to have to, goodness sakes, we are going to have to use our ketamine, I think, a little bit faster if they're agitated. Because we can't do procedures if they're agitated. I'm sorry, my son is like messaging me like 14 times here. It's because he's doing homework. Now, our non-rebreathers have these flapper valves on them. They can exhale, and their flapper, and they can, they'll open, okay, if they're breathing out fast. Here's what we're going to do. We're going to use our ECG electrodes, and we're going to place them over the top of those two holes. And then they're not going to be able to blow or aerosolize. So if we have to use a non-rebreather, if we've decided we have to use a non-rebreather because they're still confused or whatever with that nasal cannula surgical mask, I'm going to use the non-rebreather. I'm going to put my ECG tabs on the holes, and I'm going to put a surgical mask over the top of this on the patient, okay? So that's something we need to think about and do, okay? So nasal cannula, 5 liters, procedure mask over the top. Let me tell you, a cough gives about 400 liters per minute. Aerosolizes at that rate. So we need to make sure that we cover them up, because I don't want that stuff on me when they cough. So just know that. Non-rebreather, cover up those holes with the EKG pad things, and then put a surgical mask over the top of that whole thing as well. Now, I've got so many notes here, so I'm going back and forth. Our safety is of utmost concern to everybody, and it should be to you. So, always less is more. If they are apneic, agitated, or altered level of consciousness, we're going to call those the 3 A's. AAA, this is AAA different. Apneic, agitated, or altered, then we're going to have to kind of go down these steps. Put a nasal cannula on with a surgical mask. Wait. If that doesn't help them, non-rebreather on, use our ECG pads or electrodes, and then put the non-rebreather on and put the surgical mask over the top. Again, treat the numbers. Treat the patient, not the numbers, I'm sorry. If they're still a little hypoxic, but their mentation has improved, they're not agitated anymore, then awesome. Use our ketamine faster if they're agitated, because as we know, they're going to agitate. When they're agitated, they're going to aerosolize everything, okay? We don't want them to do that. So if we need to put that surgical mask, non-rebreather on, or whatever we're doing, and then get an IV and use that ketamine. If we can't get an IV because we're in their face and they're really bouncing around, IM ketamine. Let's use our resources. Our 4 milligrams per kilogram IM. It's best to use the big muscles here in our legs, in their legs, and if it's a lot of milliliters, break it up in 2 and go. I've gone, I know this isn't good, but I've had to go through patients' pants before, because it was, you know, an agitated, combative situation post-seizure, and there was no other way to do it. Because of this big muscle mass, it perfuses better and faster here than it does in your deltoids. So that's why we go here. If that hasn't fixed them, if we've settled them down with the ketamine and done our thing, and we think we need to use our non-invasive CPAP or BVM, filter close to the patient. So mask, BVM mask, or CPAP mask, and this goes right there, and then the BVM or the CPAP circuit, okay? And you have to have a tight seal. So get it tight. Don't like rank it so that their face is white and pushed out, but get that seal. It has to be the right size mask. Now we can't just cheat and say, oh, you'll be fine with a medium. If they're small, put a small on. If they're medium, put a medium on. If they're large, put a large on, okay? And the filter goes next, and then the CPAP ventilator circuit or the BVM. And if you're using a BVM, we're gonna have to have two hands holding that mask. So two thumbs on their head, like so. I don't have a BVM mask. Oh, that was my mistake. But you're going to hold the airway open and smash your thumbs down on that mask, okay? And somebody else is going to do the bagging. We have to not have leaks. And right at that mask goes the filter, and then the BVM goes next, okay? We have to do that now. This is different. Okay, now, if we do have to intubate, we are going to have to be very careful. We're going to be very vulnerable then with from those aerosolized goobers. So if we have to secure an airway, be safe. It might be, if we feel like it's going to be difficult, use our eye gels and put the filter on top of the eye gel hole, okay? So this is my ET tube. I'm going to put this filter before I intubate right there. And then as it goes in, if they cough and it comes up here, it's going to go through that filter, okay? We can still DSI, where we're going to use ketamine and let them breathe if they're not apneic. If they are apneic and we have to use a bag valve mask, remember, filter, two hands, somebody else is going to bag. Now, this is scary stuff if we decide to use this. So, things to remember about intubating. First pass, it needs to be the most experienced provider. I'm sorry, this is not the time to teach a new paramedic, okay? Or whatever, if it's going to be a hard one. I'm going to use video laryngoscopy, people. Direct laryngoscopy, you're going to be closer to their face. We want first pass success. I'm going to lube, and I'm not lubing this because we're going to wash this and use it in our bag. So, but lube the end of that tube, get it set up, put the filter on. I'm going to use my N95 as well as this hood. Okay. I'm not gonna I can't really talk very good with that N95, so we're going to pretend it's on there. I'm going to not bag as much as I can, because every time I am taking taking the BVM off, I'm breaking that seal if this comes off. So if I'm going to BVM, it's going to be through this, but I would really think more about setting up our ventilator. Now, this is an open circuit ventilator, meaning that the exhalation tube here is open to the air, okay? Now, if I've got that filter close to the patient, then what they exhale, it goes through here, then at the Y, then out on exhalation. And what we can do as well, here I'm going to show you my end-tidal fits. End-tidal, and then my circuit. So ET tube, filter, end-tidal, ventilator circuit. I was saying something, but now I can't remember. Placing a filter on the expiratory side as well. And I had two filters out here. I didn't know where it went to. But you can also place the filter right here on the expiratory side, okay? I have stuff everywhere, so I'm sorry. Alright, so I'm going to set up my ventilator first. This is DSI. So this patient has ketamine on board and they're still breathing. I've got my nasal cannula, but I'm not going to go to 15. I'm going to go to 6. I'm going to have a non-rebreather with the things closed, and then a procedure mask over the top. And I'm hoping that I'm going to position them right, have my suction on. I'm only going to use that suction if I absolutely have to. Okay, I don't, if it's going to muck up my my video, then I'm going to have to use it, but that stuff is what's infected. So remember that. Surgical mask, so we'll pretend like this is on the patient, okay? When you're ready, you have everything all pulled up, your meds for DSI, your post-intubation meds as well. We don't want them to be agitated at all, ever. So your fentanyl, your analgesic, and if they need more sedation to knock them back down, I don't want them moving. I don't want them coughing. I don't want them bucking this tube, okay? So I've set, and you guys play with this ventilator. I'm going to set it up before I even go and just let it work, okay? So it's going to either be, it's going to be lung protection unless this patient has an obstructive process as well, and that's what's messing them up. This is a normal patient without COVID, nothing changes, okay? But if it is COVID, or we suspect, so I'm going to do my lung injury approach, so low tidal volumes and a little bit higher respiratory rates. So my 6 liters per kilogram predicted body weight. I'm going to measure this patient out. I'm going to figure out their ideal body weight or their predicted body weight and multiply that by 6. So I'm going to go, just for ease, I'm going to go 370 on my tidal volume, and I am going to go 20 on my respiratory rate. Okay, you can put the FiO2, you know, the high pressure oxygen hose there and all that, but it's going. It's in AC ventilatory volume mode. Okay, so when you're ready, Remember, I have my PPE on, I have my N95 mask on, okay? And this again, I'm gonna try to stay, this is video laryngoscopy, so I'm gonna try to stay away from the airway. And I'm just gonna, and I just pulled that with my finger, just so you know. I am pulling it with my finger. I'm gonna look at that epiglottis and see that view. I don't know if you can see it, but it's there. And then we're gonna push that tube right in. This goes right on, in title. Secure it, 22 at the lip. Secure it with my Thomas tube tamer there. And this is a big thing here. It would be awesome. Verify. I see the lungs rising. So verify your end title is going to be on there. Verify. And what's good about this too is my end title is after my HEPA filter, so it's not going to get gummed up like we've been doing. And then secure the airway with that Thomas tube thing, and be alert the ED. We've got our HEPA filter on, that's a necessity, and do what we need to do, okay? So those are some things that we need to think about. I've got more, so stand by one. So just remember, if we do need to intubate, if we have to, we're gonna think long and hard about those decisions. And again, less is more. We're gonna hold back as much as we can. This is a new era here with this COVID. We're going to use video laryngoscopy. We're going to have the most experienced provider. We're going to do first pass success, minimal or no bagging. That's why we're going to use that ketamine. Have suction ready and all that, your bougie and all that, like we usually do, but only suction if we need to, because that's gonna have their droplets and spit and stuff. And maybe we should pre-treat with some fentanyl so that they don't cough. If we were using ketamine, we can use a little bit of fentanyl too if we need to. Okay, so just think about that. All right, be safe, full PPE, N95 and hood. Can't stress that enough. Now, another thing we need to think about is, where do we put in these filters? This closed circuit stuff. Again, I've been talking about that. Place it as close to the patient as you can, and as well as you can place a HEPA filter on the expiratory part of the circuit. Suction only if needed. Don't break that circuit. So be very vigilant in watching this. Don't break that seal. If you have to, this is what we use for somebody who's really been hard to get their oxygen levels up with lots of PEEP or whatever. We need to maintain that. So what we do is we clamp that tube before we let them, we're going to let them inhale, we're going to clamp the tube, and then we're going to make the change to our vent. Okay, those are things that are happening now, but we need to think about doing that now. If that, use your thumb. If nothing else, use your PPE thumb there. If it pops off, close it or bend it over or something, and then put that back on. So we don't want it blowing out at us. That integrity, that circuit, ET tube integrity is very, very important. I've been looking at the N95s and how they filter, and N95s filter 95% of the little things up to down to 0.3 microns. The SARS-CoV-2 is 0.12 microns. So how the heck does it filter? It filters it because that virus is suspended in droplets, and so it is filtering those droplets. Okay, so we're okay. Now our HEPA filters, they filter 100% down to 0.01 microns. So yay, it filters smaller, as small as that little COVID thing. So nebs. Nebs are not the answer to everything. Oh, I found that vent or the filter. So I'm putting it on the end of my exhalation port. There we go. See, it's on there. So if the patient has their own meter dose inhaler, let them use it. If they have a spacer, bring that as well. If they don't have a spacer, but they have a meter dose inhaler, this is my meter dose inhaler, we're going to make a spacer, okay? And we're going to do that with our cool non-rebreather mask. We're going to pull out that oxygen thing. We're going to put our ECG tabs on there and make sure they're nice and sealed. And this is kind of nifty. This is their own meter dose inhaler if they have it, okay, and they don't have a spacer. We're gonna put our little hose from our neb right on here, okay. So make sure it's nice and tight, and then we're gonna take the end of their MDI and make a nice seal like this. Now this is their meter dose inhaler. I'm gonna make sure it's nice and sealed, and they're gonna I'm gonna probably have to hold with them, but spray and have them hold their breath just like normal. That's how you use a spacer as well, and it gets down in their lungs, and we can do 2, 4, 6 puffs using a spacer just fine. Another thing to think about if they don't have their meter dose inhaler is on an asthma patient. Now this isn't an old COPD exacerbation that I might hear wheezing. Where we would possibly do a nebulizer in the old days, where I'm gonna call 2 weeks the old days. If this is a true asthma exacerbation, I've got my little, nasal cannula Entido thing on, and I have shark fin, and I'm looking at them, and they're young, they have a history of asthma, and they're exacerbating, then by golly, if they have their meter dose inhaler, have them use a spacer and do that, as well as Epi 0.3 IM. Now we don't do this a whole lot, but we can. We need to do that more now instead of nebulizing. But think about that, use your critical thinking skills and make sure it's not a patient with MI history and all that. Another thing we need to think about is holding CPR when somebody is at the airway trying to put an SGA down, put our eye gel down with our filter on the end of it automatically. Hold CPR. They're not saying that it's for sure 100% where we do our CPR compressions and it aerosolizes, but they're saying you guys got to think about this stuff. Some people are just doing compression only CPR and putting a surgical mask over the top of the patient. Some people are putting a mask like our CPAP masks on with a HEPA filter and then a BVM, and it's strapped to their head. And so when somebody is not doing something at the airway, it's completely sealed, and then the CPR is going. So these are things we can think about. These are ethical, difficult decisions for us. Our safety, number 4, our safety is key. These are difficult decisions we're having to make. It's going to be ethically difficult, I think, but your safety is important. Do things like Michelle posted from Dr. Hilvers to keep you safe. Those were excellent things. I've implemented that. I started doing that stuff a while ago. I'm not very good at relaxing when I'm home or actually being home, but that stuff is important too. Dr. Peterson has given us some things to think about. Number one, PPE on every call, N95, goggles, and gloves for sure. If they're possible COVID or COVID positive, we have the fashionable things on. I've given you a video on how to don and doff. I'm going to place some donning and doffing things on our bulletin board in Outback and how to do it. And I honestly think we need to have somebody read the list as we do it. Viral filter, our HEPA filters, BVM, eye gels, ET tubes, closest to the patient. Think long and hard about aerosolizing procedures. Anything mask-wise, nasal cannula over 6 liters, put that surgical mask on. The non-rebreather trick with putting our ECG pads on there so it doesn't blow out. Always our N95s. Be careful with all of that. The ERs have isolation rooms with negative pressure and help. They have RTs and 5 nurses and a doctor there. So if we can do the least amount of things, get them there so that they can do things with more protection than we have in the back of these rigs, please. It's not something that I'm going to be able to do unless I actively think about it, because we're been taught so much, or we've seen patients crump so fast that we move so fast on airway stuff and breathing difficulty. At least I do. When I see somebody struggling to breathe and can't talk and their work of breathing and they're tiring, fatiguing, man, I'm DSIing them right now. I make those decisions fast, but now we're going to have to remember, less is more, and think of these things, okay? I hope you guys stay safe. All right, bye.